Hello, everybody. My name is John Swanhorst. I am a MSN to DNP student here at the University of St. Augustine Health Sciences. I am doing my project for IPE 7050 on the reduction of alarm fatigue. I am a current clinical nurse manager that oversees a 36-bed med-surg tele floor and also oversee the telemetry room that monitors 144 beds within our acute care division. So clinical alarms, telemetry monitoring, SpO2 is right up my alley. I've been doing this for about a year and a half and always known that alarm fatigue has been an issue, but never really known how to decrease it, to truly understand it. And so this is my inspiration for why I really wanted to do this project and really dig into the research and get a better understanding for what alarm fatigue is and how we can decrease it and the effects that it can have on both staff satisfaction, but also patient safety and increased quality and safe care for our patients. Just a little bit of an overview. I'm going to start with a problem and my PICO statement of why I'm doing this and why it's valuable and why it needs to be done. Then doing a review of how I found the articles that I used, going over the evidence that I found within those articles, what my change process is and kind of how I'm going about that, what my data really showed and how I'm evaluating that and analyzing it, and then going over the plan of how I'm going to disseminate my findings and evidence. I'll go over quick practice recommendations, follow up with a summary, go over my references, and then open it for questions if there are any. So why is alarm fatigue a problem, and why is it something that we need to look at and worry about trying to decrease? So alarm fatigue really is a widely recognized safety issue within hospitals today. Alarm fatigue, which can really cause slowdown of responsiveness or desensitization to the clinical alarms, really affects the patient outcome and patient safety. And usually this is caused by an increased number of non-actionable alarms or alarms that really don't need clinical intervention. So there's alarms going off and the clinical team really doesn't have to respond to them. Maybe it's a low SpO2 that drops down a little bit, cause an alarm, but not enough for the nurse to actually have to do anything. And so it's those alarms that are going off that the clinical staff is listening to, but really not needing to do anything about. And so research will really show us that about 74% to 99% of clinical alarms really are non-actionable or alarms that are just filling the atmosphere that the clinical team really doesn't need to respond to. So my PICO statement really revolves around this, and it's for nurses in the hospital setting. Does the use of customized monitor settings resulting in fewer non-actionable alarms reduce the perception of alarm fatigue compared with default settings by the clinical staff? So we're really looking at alarm fatigue as perception based, and it's just because we decrease alarms doesn't mean alarm fatigue decreases. It's a subjective measurement looking at the perceptions of the clinical staff. So how did I find the articles that I wanted to use for finding the best practice and really truly understanding what alarm fatigue is? So I did a Sinhall complete search using the keywords of alarm fatigue, clinical alarms, telemetry, SpO2, and then I used inclusion criteria of being published between 2015 and 2019. Also English language. Went from there, I got about 196, and then even going further into my inclusion and exclusion criteria of looking at hospital-based, inpatient specifically, so excluding any outpatient services, and then looking at a population of adults. Went down to about 18 articles. From then, we were able to look at those 18 articles and choose 9 of them that I felt best fit what I was looking for to help me best understand alarm fatigue, and then also best understand the population of adults in the inpatient setting with interventions to help decrease alarm fatigue. So why is it important? What was the evidence that I found? What were the most effective interventions? All great questions. And with that, where I really started was the Joint Commission issued the National Patient Safety Goal in 2017 that really stated that hospitals needed to decrease or at least work on decreasing alarm fatigue. They really didn't give any recommendations of how to do that, other than there had to be active involvement, active effort to decrease alarm fatigue. It was shown that alarm fatigue was one of the top issues within healthcare at that time and continues to be one of the top issues due to the patient safety concern of decreased responsiveness of alarms and that desensitization to clinical alarms. Looking at the research, it's very well noted that alarm fatigue is perception based. It's very subjective. Just because I hear 100 alarms in one day does not mean that I'm going to have alarm fatigue related to alarms. Whereas my colleague may hear 20 alarms in the day, one day and have alarm fatigue. I may continue to be responsive to my alarms while my colleague may not. It's also looking at non-actionable. So non-actionable alarms, the ones that we don't have to react to. So you think about it yourself, maybe you have a beeping in your house and you've continued to listen to it for a minute or 2 minutes and it doesn't mean anything, you don't know what it is, you kind of fatigue to that beeping and you don't hear it anymore. You eventually get so annoyed by it that you go and respond to it, you figure out where it is. That's that desensitization and that's that delayed response to that clinical alarm. And the same or the 180 flip of that is your alarm clock in the morning. You hear that once and you may not get out of bed right away, but you're up. It's done what it needs to do. So that's that difference of actionable and non-actionable. So really the research shows us that the customization of alarms, the customization of the default within the piece of equipment, and the customization that you can do with each patient can decrease the non-actionable alarms by 89%. And research shows us that we know that if we decrease non-actionable alarms, there's a direct correlation between the number of non-actionable alarms and alarm fatigue. Also knowing that per the research, alarm fatigue is perception. It's not going to be the same for everybody. And so that is some of the difficulty with decreasing it, is that you really have to look at it per person, but getting a collective overview of a unit in hospital. So with this, how are we going to change? What are we going to do? So I love the nursing process and I still live by the nursing process today. I just find it fascinating. It's a really easy way for me to think. I can process everything from being a nurse leader to a clinical nurse through the nursing process. And so when I was looking at change models, Dr. Connors actually pointed out to me the Six Sigma plan of using define, measure, analyze, improve, and control. And so using this within my project, which would be set in a community-based hospital that sits right outside of a city. So in the suburbs, it's a community-based, about 200 to 250 beds, specifically looking on the med-surg tele floor. So 36 beds, typically anywhere between 9 to 12 staff members from nurses to techs that really are affected by the clinical alarms. And so working with that, using this model, we would define the problem, and that would be that alarm fatigue causes that slowness or delayed response to clinical alarms, which result in patient safety issues. We'd measure the perception of alarm fatigue. We'd be able to do that by pre and post survey collection on our nursing staff, and we'd be able to compare the pre and the post after we put the intervention in of customization. So taking that data, analyzing that data, putting in our improvement or intervention of customization of the default settings within the equipment, and then also giving the ability to the nursing staff to customize alarm settings per patient. With how we'd want to control our findings or what we're able to do and improve, we would do that by ongoing audits, reports, updates within meetings, and continuous surveys that would really measure to make sure that we're staying where we want to be and having that decrease in alarm fatigue, with having that understanding that the nurses feel like when there's an alarm, it's actionable and they need to do something about it. So to collect this data, I would use a pre and post survey that would be reflected of the perceptions of alarm fatigue on the unit. I would use a Likert scale that would ask the questions from definitely disagree, definitely all the way up to definitely agree that alarm fatigue is an issue. And with that, we would look at the percentage of people that feel like the clinical alarms are worthwhile and that they're actionable, and seeing if we can increase that number to having more of the staff feel like the clinical alarms are needed, actionable, and that they have to give an intervention whenever they hear an alarm. I would want to look at that because I know that per the research, if nursing staff or clinical staff feel like they have to be providing an action for the alarm, that is an actionable alarm, which will help decrease alarm fatigue. This would be an electronic survey that would be given out by the nurse scientist within my hospital. It would be given out and the data would be collected by her. We would be giving this survey for a 2-week time frame. Pre-intervention, we would complete the intervention of this customization over a month time frame, and then we'd have a post-survey window of 2 weeks. The nurse scientist would both give this survey and collect the results. She would also analyze this data for me using a simple t-test. We would do this to decrease any bias by me or the researchers completing this project. Once we'd have the data, we would use that data, the analyzed data, and the recommendations of understanding from the nurse researcher to really look at, did we improve? Did we decrease our goal of decreasing alarm fatigue on the unit? From that, the variable within the study would be that customization of the alarm settings. We'd have an ordinal level of measurement, and with that, we'd be able to analyze the data with a simple t-test. So it'd be really pretty easy. We would be able to look at statistic significance of our decrease and really just looking at that overall perception of that nursing staff related to the alarms on the unit and the feeling of alarm fatigue. Once I've collected the data, implemented the intervention, and then shown that we've improved alarm fatigue by decreasing the non-actionable alarms, what would I do with that data? It's worthless if I collect it, find a way to improve things, but don't actually ever use it or spread the word. So I would first start with our hospital quality improvement meetings. We hold them on a monthly basis. There's always an update on any quality improvement projects that we're doing, and this would be considered one of those. And I would show that what our intervention was and that we had an improvement in alarm fatigue. I would then share this information also with our unit staff meetings. Any type of system-wide research symposium that we have, we hold one within my system once a year, and then potentially look at any local, state, and national conferences that I could speak at and really be able to share what we did and the results that we had. The 2 journals that I would probably look to publish in would be the Journal of Critical Care Nurses. The reasoning for that is I found a lot of articles around alarm fatigue in that journal, and then also the Medical Surgical Nursing Journal, just because that's the specialty that the setting was in, and it's the specialty that I currently work in. So practice recommendations is that it is very evident through research that alarm fatigue is very subjective and a perception-based phenomenon. It's experienced by clinical staff in very different ways, and that the exposure or a frequency of alarms in themselves does not contribute to alarm fatigues. It doesn't matter how many alarms you hear in a day. It matters how many alarms that you hear that are non-actionable. So with that, decreasing the non-actionable alarms will have a direct effect on decreasing alarm fatigue. Evidence shows us that the best way to do that is customization between our natural defaults within our clinical equipment and then also the customization that we can do per protocol on each patient. In summary, I talked about the problem that we have faced having alarm fatigue within our hospitals and my PICO statement of trying to improve alarm fatigue by the customization of alarm settings. I've reviewed my search criteria and how I went about that, the evidence that I found within my research, the change process that I would use, the database evaluation of all of the data that I collected through pre and post surveys, how I would share this data, and then any of the practice recommendations that I have for customizing your clinical equipment and also customization per patient that the nursing staff can do. That customization is the best and the most evidence-based way of decreasing alarm fatigue within our hospitals. Here are my references that I use. And if there's any questions, please let me know. Thank you.